We talked about the detectors moving around, right? And we found that in which generation? Thank you. Samantha was like, no, it's not the first. The first did what? Side to side. Side to side, called what? Translate. Then rotate. And then translate it back, right? What was the word here that really threw you? That would really be able to say, oh, this could not be the first generation. Continuous. What had to happen when it translated? It had to stop. Rotate, then translate back. And I say rotate with my head, but it's really the two, right? It had to stop. So when you're looking at your words and you're looking at your tasks, all of these clues are going to be in the description. Continuous. Through the gantry, now it's talking about a second thing. Okay, well before, I changed degrees and it would take more information and went from one side to the other side. Okay, perfect. Here, we're getting that voluminous scan in a spiral or helical path. So now we're requiring all the way around, anterior to posterior, lateral to lateral, volume imaging. Volume imaging. That's a lot of data that's being acquired, is it not? A lot. So when we're thinking about the continuous motion of the X-ray beam and the patient now moving into the gantry, because you set your central ray. I'm going to call it central ray for right now. You set your central ray. You move, and then what happens? It's programmed, right? You set your protocol on the console, and the table does what? It moves the patient in sync with the scanning. So with the gantry, with the X-ray tube and the moving about. This right here is going to be determining the slice thickness. It's eventually going to be the speed of this table is going to, if it's not in sync, come up with some type of artifacts. So all of these things have to play very, very in sync in order to get the right images for that, okay? So again, when we talk about volume scanning, we're talking about this being a technique where volume of tissue, by moving the patient continuously through the gantry, and the scanner is rotating around continuously. So the patient is going in, and the X-ray is going around the patient. Make sense? As you would see this right here, the path of the X-ray. Multi-slice scanners, using a multi-detector, again, kind of saw this back in, but this is not so much of the detectors going side by side, where you have like a larger volume, a larger area to cover. So if you had a pencil beam and you had a small detector, let's just call this 5 by 5, don't remember that, but you just doubled it, that's a multi-detector, right? We talked about that. This is a bit different. This one was side by side, and we saw in generation what? Very good. You guys are coming with me, see? This is different. Now what's happening with the detectors?
It's adding a slice, so it's going
adding
thicker.
To where though? To the side?
It's adding more, kind of like a cake, adding more slices to it.
Right.
Yeah.
So before, when we were here, it was capturing this data on one scan.
Layers.
All of this data right here, the thickness, the width, remember? This is all it's, because you can only capture data of where you're scanning, right? So every pass, this was the limit, this was the width of that image receptor or that detector. But now if you start placing detectors lengthwise along the plane, you are now having a multi-slice detector. Because you're getting multiple slices in one spin. I'll say that again. You go from one slice, one spin, 1, 2, 3, 4 slices in one spin. Because the detectors are stacked in a different way. Does that make sense? It's not just a necklace ring around, it is now a wider amount of coverage. Yeah? Everyone see it? I will pause there for dramatic effects. We're good? Don't need to labor on this anymore? So what's the difference between a multi-slice CT? You're increasing the number of slices per revolution, revolutions per spin, per scan around, per this. One slice, but if you put all of these together, one spin would have gotten all of this as a multiple slice. Make sense?
So the detectors,
They're now longer.
okay.
They cover more volume of area. So as it rotates one time around, it captured all of this. Then I can go here, and then I can go here. So technically, I'll get the same volume with less spins. Make sense? Yes.
And what generation are multi-scanners?
They're just called multi-slice detectors.
Oh,
They're not
detectors.
necessarily called into a generation.
So it
You're
could
just
be, it
getting-
could be any of them.
They're getting fancy with it. Yeah,
Well-
it's not identifying those, it's just calling them multi-slice scanners. And I think these are just the different versions that are coming into the generations. But remember, it's
Oh.
almost like your package deals. What are you buying? What kind of equipment are you buying? iPhone 16, iPhone 12. What are the features that it has? Same brand, it's just different packages with it.
Like a, okay. And what do we use for here, yourself? What generation do we use?
Third.
Third, okay.
Mhm. Third generation. Because the more you have, it's almost like when you buy the iPhone 16 right when it comes out, is it more expensive? It's a lot of money. And then you start to wait till you can afford that. And so, what's the difference? What would be the difference theoretically when you go back and you sit here? What was the issue that we have overcome over time and time? 1, 2, 3, 4, 5, 6. What did we overcome? Time. So if you're able to capture more under one slice, theoretically that saves time. And putting on my HR hat or my admin hat, saving time means patients move faster and more patients come in and that's more revenue to support, right? Because x-rays cost money or they generate money. So if you say, I've only done my 6 scans today, I'm good. Chances are no, your machine can do 60. So when you save time, that means you can do more. Here is just another way of saying the multi-slice CT scanner allows more space, more volume to be acquired per rotation, as opposed to here, I'm sorry, James, but as of here, you're doing one slice, one round, one slice of rotation. Okay? Yes.
And for the gantry, for centering, it would be like a regular X-ray, how we do it in the rooms, like T7 for chest.
Yeah.
Exactly.
It's specific protocols. It's not going to be like T7, but it's going to be specific protocols.
Oh, okay.
Yeah.
That's
So
like
if we're going to get to the machines
Oh,
itself.
okay.
What?
oh, it's like, it has like two, like
Mm-hmm.
Mm.
Aim the laser, and it goes to the protocol because some people, when you go into, and this is one of the things that I will say, like it's like you're not going to go for a Towns and aim at the glabella or it's almost like, oh, aim right here, just like I did when I said, where do y'all send your first chest X-ray? Somebody said T7. Where do you collimate to? Everybody's going to show you differently when you go in with different tags. Oh, you just right here. So I just went right there. Oh, okay. because you're gonna get that volume imaging. You just wanna be able to make sure your or your scan region covers what you need to cover and a little bit beyond. Because again, those axial images are gonna be what? Reconstructed. All right, so do we know the difference between a multi-slice CT scanner versus a generation number 2? What is the difference? It's not going to be the width of the detectors, right? So it's not going to be here, not side by side this way, but it's now going to cover volume and more volume and less rotations or more rotations? Less rotations, perfect. Okay. The dual source CT scanner, again, these are just different, they're getting fancy with it, but you can see you still have a fan beam portrayal here, you have some detectors, features 2 x-ray tubes. So the dual source, there's that word, because you gotta look at your words to say, okay, what is it talking about? What are we saying? We know the x-ray machine is the source of energy. The x-ray machine is the source of the energy. We cannot get to digital, we cannot acquire data if we do not have x-rays to emit them in order to pass through the patient. So the x-ray source is the x-ray tube. There is an x-ray tube in every CT machine. There is an anode and a cathode in every CT machine. We good? Y'all are looking at me like, what's an anode and a cathode? I'm afraid right now. I'm kind of scared. Are we good? Okay, good. So we see, why would we need 2? Very specific. Why would we need 2 x-rays? Speed. Capture. Speed. Because we know that an x-ray tube gets hot, right? Too much bombardment of those x-rays onto the anode does what to the anode disc? Burns it, pits it, damages it, and then can we just replace an anode disc? Can we open up the tube and replace an anode disc? What do we have to replace if our anode is damaged?
The entire thing.
The entire tube. The entire x-ray tube. And if your x-ray machine is down, can you do patients? You can't do patients, then what happens to you? Go home early.
Flex you.
We're not generating any revenue. We're gonna save costs and budget. Go. You're like, but I gotta work. It's a ripple effect. So, this dual sources is going to be basically speed. Why do we need speed? In CT, we already said it goes, we can do up to 300 scans in under a second. Here, it's really just to get motion. It's speed to get in between the beats of a heart. So when we're looking at artifacts in motion, it's not going to change. X-ray is X-ray. If you move, you're going to have some type of blur, right? Blur reduces spatial resolution. What is spatial resolution?
Just in a different.
No? Okay, spatial resolution is the accuracy that you can depict anatomy. When something is very high spatial resolution means it has clarity. You can see. We call that efficacy. When you have something that is a diagnostic efficacy type image, means that the radiologist in theory has the ability to determine what is wrong with the patient. If the patient is blur, then you reduce the efficacy or the ability to diagnose issues. We're not taking images for the sake of it. We're taking it so they can be read and the person can be diagnosed and get some type of treatment. What the treatment is depends on what is being diagnosed, right? What is being diagnosed depends on our ability to provide clear, high spatial resolution images. If you have a beating heart, and how many of you get nervous when you sit down somewhere in the hospital or in the doctor's office and you don't know what's happening with you? Chances are your heart is beating super fast because you're nervous. You're high angst, right? You're like, I'm dying. My heart's going. And that's what this machine is used for. So you may not see this as a common routine type CT machine that's that's placed everywhere. It's usually going to be used in some type of cardiac imaging. Yes.
So if you have the option of doing a dual energy CT, then that's a dual source CT scan.
Yes. It's a dual source, meaning there's two X-ray tubes, not two detectors, but two X-ray sources and detectors. Remember, because we never aim at X-ray source unless it's going to a detector. Yes.
So if one tube slicing this way and one slicing that way, wouldn't it make the image look different compared to just one detector? I mean, one tube?
Well, remember, it's all going to be reconstructed. But are you asking, is this likely going to have a different type of algorithm than one that without the dual detector? Then yes.
Yeah, like how, yeah.
Yes.
That's what I was asking.
Because as long as it's acquiring data acquisition here, the energy is going to be emitted and then it's going to be converted into digital, but it's going to be depending on the algorithm to determine how to put those into the pixels so that you're not getting a mutated type image because of the different angles of the two. All right, good. So CT angiography, this is basically another area where we are looking at what flow, speed, things like that. I'm not really getting too close. Have you seen a lot of angiography in your space?
Do the gated heart studies, I don't know if that would be
Yeah,
considered.
it is. The gated
We
heart
do a
study.
lot of them.
You're basically saying the gated, you're using a machine. So great question. So do I have to have a dual source CT and because I'm doing a heart study? No, you don't. There's other types of software or gated or protocols that will go back and do a time sequence to say, hey, I'm in between. So usually those people are tied up to blood pressure machine and they're the EKGs and they're determining what the sequence of heart and that's what's programming to take the images in between.
We do a lot.
Yeah. So when you're able to start comping on them, you're like, yeah. All right. Okay, we're almost there, guys. We're almost there. So methods of imaging, getting heart without compromising spatial resolution. That's what cardiac CT is known for. So would you go out and buy a machine or convince your administrators or your chiefs out there to say, I need an electron beam or I need a multi-slice or I need a dual source? You would definitely have to have a reason as to why. So if you're working for a cardiologist and you're constantly doing heart type images and it is going to support the reasoning because obviously all of these are not common, they're not routine, so the prices are likely going to be much more substantial. And then you have to also think about the repair, but we'll get to repair later. The application of CT screening. Screening is a controversial tool that is used primarily to detect diseases. What did I just say that we needed to produce in our images in order for the radiologist to do what they needed to do? Spatial resolution. Yes, the spatial resolution is to contribute to what? Diagnostic efficacy. So in order to have diagnostic efficacy, meaning that they are absolutely going to be able to determine, in theory, that this x-ray that was produced by Romer, and it was so beautiful because it's artifact free and it's in sync and it was just done beautifully, reconstructed, the algorithm Cormac gave was just outstanding, then in theory you should be able to provide a diagnosis. Why do you go to the hospital? Why do you go to the doctor? To find out what's wrong with you if you're there, right? You normally go to the doctor. Well, we do because we work there. But if you were just going to the doctor's office, you will want to know if something is wrong, right? So if you're taking x-rays, if you're feeling pain, blank pain, you want to be able to say, is it a kidney stone? Is that what I'm dealing with? I want to know, is it a tumor? Is it cancer? Is it all these different things? And we should be able to provide that. So when we're thinking about CT screening, it is that primarily to detect diseases early in healthy individuals. Now, why is this becoming popular? This is a trend. CT screening. My husband did it. What do you think is a trend?
I mean, are we we just talking about like people wanting to do more preventative stuff, or just, you know, maybe the hospital's ordering a lot of CTs, or just the preventative?
Because right now, if I need a CT, it has to be ordered by my physician and it has to be cleared by my insurance, right? But unless it's an emergency case, they're gonna probably waive it because my life matters over a bill, right? So no one's gonna stop you because you can't pay a bill or your insurance is not verified, it's gonna be done. But if you go in there and you say, oh, I got a cough, I need a CT, chances are you're not gonna get that. You're not. You don't justify, your symptoms don't justify. How many have you seen an X-ray, a requisition come in for CT say for cough? No. You're like, no. For a chest X-ray, a cough, you're like, oh, that's justifiable. That's permission granted. That's recognizable. Here, CT screening is now becoming a trend because of that preventative maintenance. We can start to see that in nuclear medicine, and you're like, ooh, if I can catch cancer down to the molecular level, I want to catch it early because my survival goes sky high. So for the fire department, my husband works for the fire department, this was something that was covered by them. Because what are the common things for firefighters? Lung disease, cancer, colon cancers, things like that. So when you think about it, a whole body imaging, you give me one, I'll know early on if I have some type of disease, right, that I can prevent and catch early. That I normally would have to have a symptom to manifest before I go to the doctor and they can order me a CT screening. So this is a trend that we're starting to see, right? This is a trend that we're starting to see. We call it life scans. Why life scans? Because they promote life. If you have cancer, what is the number one thing you're trying to acquire most of? Time. So if you can catch it early, your prognosis goes super great, and you're in remission before you know it after you get your treatment. But you catch it late, prognosis goes down, right? When you start getting into stage 3, stage 4, then you're heavily relying on medical intervention. So this is becoming a trend, so you may start seeing that. 3-dimensional imaging, again, this is something that is back from, it starts from where? Huh? Okay, it starts from the axial image. What image is this? Vaginal, okay. And then you have 3D reconstruction. This is where we have that ability to start adding color, right? Before we're getting out of the monochromatic type of display. We're now looking at images like in color, right? These are the fascination, that's software. So when we think about the special algorithms that are used to transform this into this, because this into this, started with ones and zeros, crests and valleys, crests, valleys. That's all it is. Isn't that amazing? I just want y'all to be like, no, right now. That's amazing. It's amazing to me how long we've come. All right. So digital imaging processing again involves different types of steps. We can go this and we can sing this song all day. I am convinced you guys know all of these steps. I am convinced you know what happens in step 1, step 2, step 3, what devices are part of those steps, what energy is being converted, where the math comes in, where it's displayed. If I want to send it upstairs, how do I do that? I think you guys have the overview. Would you agree? You are not convincing me. No? Start over? No, she's like, no, please. No, so could we go through all of this? If I send somebody to the board and say, mesmerize me, talk to me. Step 1, step 2, James, why are you making that face? What am I missing? Am I off the mark here? Or you guys got it and you're just tired, it's 9 o'clock.
I think we could do it. We could do it.
So?
Yeah.
Some are nodding their head more fiercely than others. Some are like, let me get to step 1. Remember, how you feeling? Am I laying it out? Can I move on?
I think so.
What honesty. Alright. Again, so the science, the physics, we're going to get to it step by step. Really, again, this is just an overview. Radiation dose studies, we know that we're talking about high source of X-ray in order to get all that volume of imaging, and then again, it's repeating and repeating and repeating and repeating itself. So it's dose, 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 dose. However, we're making some great strides. Way better than 1973, right? Where people were getting radiation sickness, and we started to see cases with pediatrics and leukemia. There's correlation. So case studies, trial and error. Trial and error. Ours is what's basically giving us our evidence base to say, hey, we need to have better practices in radiation. So that being said, remember the rule about X-ray energy dissipating? Who, when you walk into an X-ray room, who holds the radiation?
The patient.
The patient. It's a good time. Walk slower. Hello. You feeling okay? Hi. We're ready. give it a few seconds before you get there. Let that Compton radiation scatter across out of the way. All right. Different types of commissions, committees. When we talk about this, we're going to talk a little bit more towards the end of the semester of these different types of organizations. But again, this is just really highlighting that we are looking at the trial and error. All the case studies are out there with high dose related CT exams. Another reason why it's expensive, right? The machine is expensive compared to X-ray. Another reason why the doctor may say, no, let's not do repetitive CTs unless it's absolutely necessary. The risks outweigh the benefits. If the benefits outweigh the risks, then that's why we do that. Okay. The radiation dose schemes, you guys have kind of looked at this. You have the slides, you can go back through it, but really pre-patient filtering technique is going to be important. So just aim the X-ray because again, it's a fan beam. We know that the areas out to the side are going to have more opportunity for Compton scatter. So having these filter opportunities are going to be essential, and we'll talk about those filters. Quality control, as I mentioned earlier, every exam before we start using the machine must undergo a quality control testing. And so just to make sure that the machine is operating the way that it's supposed to be operating. Because if you found out later in life that, hey, all of this machine was not calibrated and it was off, then all of the scans and all the people that you expose radiation to, that's a red rule here in Harris Health, so don't do that. So make sure that the person who's opening up for the shift or whatever is likely going to do that quality control because it has to be logged and documented and shown to the radiation safety officer. This is just basically talking about other types of instruments to use for quality control, which is the water phantom. Y'all know what a phantom is? Yes? Good. And so this is just how we're going to determine that. All right, we got a pop quiz. I'm gonna let y'all do it.
Oh, just answer.
Yeah. You want me to call you on me? I can call
Oh.
Marquita. Huh?
Council.
Very good. All right. Zindu.
Attenuation.
What is it?
Attenuation.
Is the collection of X-ray transmission measurements from
Oh, did I
the
have it just-
patient. Very good. But this is practice, not graded. This is practice. So we want to say the collection of X-ray transmission measurements. This is going to be data when you think about it. Okay. All right. Well, what collects this data? James.
What collects? Detector.
Very good. I like it. Romer says he's next on this next question. Oh, this one's a bit different. This was something that we just kind of.
Ideograph?
Very good. All right. Alexis, I'm coming to you. The fan beam was used in the blank generation CT scanner, is she right? Everybody's nodding their head in support. Perfect. You see, you guys are learning. I'm excited about that. You are learning, okay? Or did y'all look up all the answers? Y'all just scrolled up on the PowerPoints right now, because all of these answers are there. Fifth generation of CT scanner is what? What is that called?
Electron beam.
Very good. That's it. You guys passed. Chapter 2. We're starting on it. If you guys are not, they're in your, well, you don't have Clover Learning, but there's a physics replay. Because I guess when I'm laughing,